Hello class, this is our lecture on the nursing management of a client with a fracture. So for our clinical overview, we have here fracture is a break in bone continuity that occurs when the force exerted on the bone exceeds the strength of the surface to resist the stress. Fractures are accompanied by localized tissue inflammation and muscle spasm. Fractures occur directly from trauma or indirectly from disease. So some risk factors that we see, again, we just mentioned trauma. Trauma may be associated with a fall or from a motor vehicle accident, high-risk lifestyle, participation in high-risk sporting activities. Many of your football players, people that participate in high-contact sports, they are at risk of having fractures. When we talk about malnutrition, when we see patients that have calcium deficiencies, protein deficiencies, vitamin C deficiencies, this predisposes that person to being at risk for fractures. We learned about calcium during our fluid and electrolyte lecture, and so we know that 99% of our calcium is stored in our bones. So when we have patients that are malnutrition and they're not receiving that calcium, well, then it predisposes that patient to being at risk for fractures. Osteoporosis, we're going to talk more about that in an upcoming lecture. And then advanced age is also a risk factor for fractures. As we age, we know that different things go on with the body. We talked about hypertension, orthostatic hypertension. Older adults may be depth perception being off, visual changes that occur with advanced age. And so these are things that put the older patient at risk for potentially falling and developing a fracture as a result of that. Decreased circulation puts a patient at risk for fracture. We know that our body, the heart is responsible for pumping oxygen-rich blood throughout the body. And so if we have decreased circulation, then that part of the body will not receive adequate blood flow. And so if we have blood flow not being received to the bone, and then it's going to be at risk for breaks. Immunocompromised status. We know that our immune system, the purpose of it is to fight off infection and to fight off bacteria. When the person is immunocompromised, then that person has no ability to fight off infection. And so the same way that our immune system can come under attack, the bones can also come under attack, and that will predispose them to disease and to the possibility of breaks. The presence of infection, systemic or osteomyelitis. Whenever we see osteo means bone, so osteomyelitis, we know itis means some type of inflammation, and so we have bone inflammation. The infection, again, predisposes a person to fractures. And neoplasm, we'll talk more about cancers next semester in 201, but anytime we have a cancer is a disease or a sickness, and it puts that person in an immunocompromised state, and the body is has a reduced ability to fight off infection and disease when the person has cancer. Corticosteroid therapy. This is here because corticosteroids, many people will take corticosteroids for inflammation. During allergy season, you'll see a number of many people will take anti-inflammatories or corticosteroids. You've probably heard of patients being on prednisone before. Prednisone is a type of corticosteroid. It's a really strong corticosteroid, but in the process of the corticosteroid doing its job, it suppresses the immune system. It suppresses the immune system, and it also kills the disease along with suppressing the immune system. So when we have a person that's on corticosteroids, the immune system becomes suppressed. And so again, if the immune system becomes suppressed, the body loses some of its ability to fight off infections. So this will be good for you to just file in your memory whenever we have a patient that's on prednisone or corticosteroids. This is a person that wants to not be around large crowds of people because they are in an immunocompromised state. Cushing's disease is a problem with one of our adrenal glands, and we'll talk more about that in an upcoming lecture. And also falls. We've already talked about falls predisposing a patient to fractures. So on page 1636 in your book, it talks about the different types of fractures, and so you will want to make sure you read the chart on page 1636 and familiarize yourself with the different types of breaks. Comminuted. This is the bone that is splintered or broken into several fragments. We have a complete fracture. A complete fracture is when the bone is completely separated by breaks and it is in two parts. We have a compound fracture or an open fracture, and with this is when the skin is broken, and it may be with or without protrusion of the bone. With a compression fracture, this is when the fractured bone is compressed by another bone. And we also have a Greenstick fracture. With this is when one side of the bone is fractured and the other side is bent. It commonly occurs in children. The name of this fracture comes from the analogy of breaking a young, fresh tree branch. You may, some of you may have heard of a switch before. So if you know what a switch is, this is when you tear a fresh limb off of a tree, and if you think of how the end of that limb looks once you take it, that's kind of what a Greenstick fracture looks like. You have one side of it being bent. One side is fractured and the other side is bent. And as I said, it typically occurs in children because children have bones that are still in the developmental stages, and their bones tend to be softer than an adult. So we also have incomplete fractures, and with an incomplete fracture, this is when the break is partially through the width of the bone. We also have a simple closed fracture. And so for the purposes of this lecture and according to this book, we're just going to go with closed. And so with a closed fracture, this is when the bone is fractured but the skin is still intact. A couple of earlier slides, we talked about an open fracture, and this is when a person has a break in the continuity of the skin. So remember, a person can have an open fracture or they can have a closed fracture. With the open fracture, this is when the skin is not intact. And so you also have a figure of that on page 1636. So the signs and symptoms that a patient may possibly have a fracture. The person is going to have pain or tenderness over the involved area. They're going to have a loss of motion in that area. Most people, when they have fractures, it hurts for them to move it. They may also have crepitus, and what crepitus is it's a grating sound when bone is manipulated. So when a person, let's say they fracture the leg, if that person moves that leg too much, then you're going to hear a grating sound. When we hear crepitus in an area of a body that we think has a fracture, we want that person to keep that area as still as possible. If not, if they do a lot of manipulating, we can further impair that fracture. Okay, we can make maybe a closed fracture become an open fracture if they continue to move that extremity. So we would not want that person to manipulate that area much. And this is an obvious deformity. They may or they may not have an obvious deformity, and this will make sense when you look at the different type of fractures on 1636. If a person has an open fracture that protrudes, then that would be an obvious deformity. Well, if you have a patient that has maybe a longitudinal fracture, which you'll see on page 1636, this is when a person has a fracture that's along the length of a bone. Well, that's not a break in that bone, and so that person would not have an obvious deformity. So with that patient, we would have to look at these other signs and symptoms to let us know that there's possibly a fracture. The person may also have edema associated with it, muscle spasms, impaired sensation. The person is going to have they may have may lose pulse distal to the site of the fracture. So if they have a fracture that's in the upper, maybe in the upper arm, then when we go to assess the radial pulse, then the person is possibly going to have a loss in that pulse. There may be protrusion from the skin. Again, it depends on the type of fracture, and there may be damage to underlying structures such as the muscle, the blood vessels, and also to the nerves. Other signs and symptoms that we may see associated with the fracture: ecchymosis, and so this is one of those terms that you should have remembered from health assessment. We know that we have ecchymosis and we also have petechiae. And with ecchymosis, this is large reddened spots that we see. Petechiae, those are those pinpoint red spots. But ecchymosis, ecchymotic area are going to be your larger reddened erythematous areas. And so these are, again, the collection of blood greater than 1 centimeter, because blood is outside of the vascular tree, but it's still within the tissues. And then something else that we may see is an obvious shortening of an extremity. So diagnostic and laboratory tests that we see, of course we can do an x-ray. An x-ray would definitely show us a break in the skin integrity. And then you also have something here called a bone scan. And so what you will want to do, depending on how well, how detailed your knowledge is on the musculoskeletal system, you may want to consider reading chapter 62 as well. But in chapter 62 on page 1625, it goes over the different diagnostic studies that can be performed on the musculoskeletal system. With a bone scan involves injection of an isotope, a radioisotope, and it's done to see how the bone is taking up this radioisotope. And so it says here on page 1625 that we see increased uptake when a person has osteomyelitis, osteoporosis, primary and metastatic malignancies of the bone. And also we see it with certain type of fractures. So we could do a bone scan, and if that person has increased uptake, then that means that the person could possibly have a fracture, or they could possibly have metastatic bone cancer, or osteomyelitis, or osteoporosis. But if we suspect that the person has a fracture, a bone scan could help us in diagnosing that. So our therapeutic nursing management. First of all, prevention, avoidance of high-risk activities. And so things like skydiving, high-impact sports, or rollerblading. Of course, as nurses, we want to always educate our patients. And so all we can do, people like to try different activities. So we couldn't tell them to avoid these things, but we want to make sure that they're doing these activities safely. So if a person likes to rollerblade, then, you know, of course they need to have a helmet on and their protective equipment. Avoidance of safety hazards, especially for our older adult. Throw rugs, pets under the foot, untreated vision problems, side effects of medications. And so we talked about the patients with hypertension and the different ways that hypertension can affect the patient, especially when we're treating them for hypertension. We know that a patient that's receiving hypertensives, they're at risk for hypotension. And so we would want to teach that patient to change positions slowly, to let their feet dangle before they stand up. If they don't, they abruptly change positions, then they're at risk for falling and sustaining a fracture. Untreated vision problems, our diabetic patients, and I know you learned this with Miss Williamson, want to have a patient that's a diabetic should have yearly visual exams. All of us should, but especially the diabetic patient, because of the retinal changes that happen as a result of diabetes. They have small vessel changes with diabetes. I know you all know this, but the retina is one of those small vessel changes that we see associated. So the diabetic patient has to have frequent annual vision exams. Throw rugs. I typically tell this little story about my grandmother. My grandmother had maybe about 12 vinyl steps with metal lining. I don't know how to describe it, leading down to a concrete floor. Well, many of you, maybe you've seen the colorful yarn rugs that many people used to use years ago, and for whatever reason my grandmother didn't get rid of hers. She had that rug at the top of those metal stairs, no back into the rug, and you know, I'm Nancy Nurse now, so I just see an accident happening, and so I would take that rug and hide it from her, because why would you have a rug with no type of back and no slip resistant at the top of steps? And so many of our older adults don't know this. They don't think of it. They just think it's a pretty rug and this is a nice place for a rug, because she had it in a location in front of a door that was leading from the outside. So she's thinking, I don't want water to be trapped inside of the house. But that was not the right place for a rug that's not slip resistant. Prevention. Regular exercise, which strengthens muscles and helps with coordination. I guess this is a good place to interject the purpose of exercise. We talked about, again, fluid and electrolytes, and we talked about calcium. And so when we had the person with hypercalcemia, that meant that we had a lot of calcium in the bloodstream and not a lot of blood in the bone. And so what we learned in that lecture is that we wanted that person to do muscle training exercises, some type of strength training, because we wanted that calcium to move from the blood, and back into the bone. And so when we have a patient that has osteoporosis, we want calcium to go back into the bone. And so when we do strength training exercises, then it forces calcium back into the bone. And so strength training exercises, again, it strengthens our muscles. Okay, and so it reduces the risk of fall. And strength training and regular exercise also helps with our coordination. And so all of these are different types of prevention of fractures. Again, we talked about that person not practicing safety with those high-risk exercises, and also the person having some type of regular exercise. When we have patients that are immobile, immobility is what causes calcium to leak from the bones. Activity is what causes calcium to go back into the bones. So when we have our patients that are immobile, patients that are on bed rest, maybe our patient that has some type of cognitive deficit, our patients that are in a coma, or that are in some type of immunocompromised state, we're the person that's going to provide activity for that patient. And so the way that that person is going to get their strength training is from us doing passive range of motion on that patient. We're going to move those extremities. We're going to move those elbows back and forth. We're going to move those shoulder joints. We're going to move those legs back and forth, do those abduction and abduction, flexion and extension exercises that we learned about in health assessment, because the patient can't get up. And so by moving, we're helping to manipulate those extremities, but we're also helping that calcium to go back into the bone where it needs to be. And so we're going to assess and we're going to monitor. We're going to monitor the person's general physical activity. We're going to monitor the person for indication of shock. The bone has blood in it. Our large bones, the femur is a very large bone, a very vascular bone. And so if a person has a break in their femur, they can lose a lot of blood from having a break in their femur. And so we want to assess that person for shock, because remember, again, we know that the heart is responsible for pumping oxygen-rich blood throughout the body. So we have a break in that bone, we're losing large amounts of blood from that bone. Well, then we don't have blood being adequately circulated. And so that puts the patient at risk for shock from a break in the bone. We also want to monitor pain status. Now, in the acute phase of a patient developing a break, in the acute phase, we could probably give the patient something a little strong for pain. And this is in the acute phase. We want to monitor the client for an elevated temperature. Again, we know that the person has a fracture, but remember, disease can also cause that person to have a fracture. So again, we're assessing and we're monitoring. When we're doing our physical assessment, our history and physical, we want to know what happened. Okay, did the person stand up and develop a break? That's different from a person having a motor vehicle accident. It's obvious why the person had that break. A person that fell from a ladder, it's obvious why they have a break. But the person that stood up from a chair and they developed a break, we don't know why that person developed a break. So we've got to assess. So again, if the person has an elevated temperature, if I break my leg because I fall from a ladder, I may not have an elevated temperature. But if I have osteomyelitis, which means that I've got some type of systemic infection and some type of infection in the bone, then I might possibly have an elevated temperature. So again, this is all a part of our assessment and our monitoring. When we have a patient that has a casted extremity, again, and I may not have mentioned this, this is a very extensive chapter, so you're going to want to read the entire chapter. It goes into detail with the different type of surgical procedures. It talks about open reduction, internal fixation. It talks about casting. Also, it talks about traction. So you will want to familiarize yourself with all of the different type of procedures for fixing fractures. So when we have a patient that has a cast, we know, we've all seen a person with a cast. Casts are applied to the outside of the body. And so on page, let's see, on page, it's definitely in chapter 63, But when we have a patient that has a casted extremity, we want to assess that cast for foul odor. We also want to assess the casted extremity for any type of drainage. And we also want to assess for hot spots. And so this is us going in. We have that patient with the cast. We're palpating all around that cast. If we notice a hot spot, that's not a normal occurrence. That means that that person may have an infection developing. Some type of irritation has developed, and that patient may be developing an infection underneath that cast. And that puts the patient is possibly going to have that cast removed. We also want to make sure that we're doing an assessment of the extremity that's associated with that casted area. If I have an arm cast, I want to make sure that I'm assessing the skin above and below that cast. I'm looking at the fingers. If the fingers are pale or blue, then that cast may be too tight and it may have to be loosened. I'm also noting any change in temperature from warm to cold. Again, that means that the person isn't getting adequate blood flow to that area. We're also assessing for pulselessness. All of these again mean that that cast may be too tight and the patient isn't getting adequate blood flow. We're also assessing for excessive edema above or below the cast and decreased movement. All of these things have to be assessed every day. Because, again, these are indications that the cast may be too tight. It may also mean that, again, the patient is developing some type of edema or inflammation in that area, in that extremity that's casted. So this may indicate that the cast will have to be removed. Again, we're assessing the client for reports of numbness and tingling of a casted limb. The client may report increased pain or burning under the cast, and the client in a spica body cast may complain of nausea, vomiting, or abdominal pain. On page 1640, there's a figure 6312 that shows you the different type of cast that a patient can have applied. And on it shows you a spica cast, a double hip spica. What I want you to make sure that you're familiarizing yourself with when you read this chapter, knowing the different type of injuries that the different casts are used for. And so with the hip spica cast, as you see on page 1640 again, the person has a cast that falls beneath the nipple line, and the person's hips and legs are enclosed. On this page, it talks about cast syndrome. And with cast syndrome, we typically see this when a person has a body jacket cast. And so with a body jacket cast, if it's applied too tightly, then the person has pressure on the duodenum. And so when this happens, the patient has abdominal pressure, and they also have nausea and vomiting. And so what we want to make sure we're doing when we have a patient that has a spica body cast is making sure that we're assessing the bowel sounds, and we're assessing for decreased bowel sounds. And so what you have to remember is what constitutes decreased bowel sounds, what is normal bowel sounds, and what is decreased bowel sounds. So our nursing activities, we want to provide emergency treatment as needed. Again, we want to immobilize without altering the position of the deformity. Again, if we do too much manipulation of a fracture, we can increase the severity of the fracture. We can make a closed fracture, an open fracture, or we can, with too much manipulation, when you're looking at the different types of fractures, again, you can cause a fracture to become comminuted, or make those little the bone break into more fragments as a result of manipulating it too much. If the person has an open fracture that's protruding through the bone, we want to make sure that we're covering that area with a sterile dressing or a clean cloth. We want to control bleeding if present, and we also want to make sure that we're administering pain medications as ordered. What I want you to make sure that you remember, when we have patients that have fractures, what we do on this patient is called a neurovascular assessment, and this is on page 1642 of your book. But what we're making sure that we're doing, again, we're checking that area, especially distal to the site of the fracture, making sure that we're checking that site, and we're assessing for a pulse. We're also assessing capillary refill, we're assessing color, we're assessing temperature. We're also making sure that we're assessing for sensation in that area. Again, because we could have blood flow being affected to that area. And so just because a person has a fracture does not mean that blood flow has to be interrupted to that area. So if we have a patient that has pulselessness to that site, then that's a problem. It may be decreased, but it should not be absent. So we want to make sure that we're doing neurovascular checks to an area distal to the site of a fracture. We want to make sure that we prepare the client for realignment of the bone, and this is done through casting, splinting, traction, or surgery. So in providing care for the client in a cast, we want to position the client so that warm, dry air circulates around the cast for faster drying. We want to use gloves to touch the cast until the cast is completely dry. And we also want to make sure that if we have to manipulate the cast, that we're doing that with the palms of our hands. If we lift the cast that is not completely dry with our fingertips, then we make we can make permanent indentions in that cast, and then that would cause irritation to the person's extremity underneath. If any drainage is seen on the cast, if any drainage is seen, we want to make sure that the cast is completely dry. If any drainage is seen on the cast, it should be outlined, dated, and timed so that it can be monitored for any additional drainage. We want to elevate the cast above the level of the heart during the first 28 to 48 hours to prevent swelling. Remember again, if we're letting that arm lie dependent, then we've got a broken bone. It can continue to bleed in that area, and it can continue to swell. So if we elevate it, then we're helping that blood, extra fluid to continue to circulate back to the heart. So we want to make sure that we keep that area elevated, because remember, now we've got a cast on that area, and so we don't want that area to become any more edematous, because now we've got a cast in that area that can cause constriction. If we have a patient that has a leg that is casted, we want to support the foot at a 90-degree flexion angle to prevent foot drop. We want to instruct the client with a cast. We want to remind the patient with the cast to exercise joints above and below the cast to maintain strength and mobility. We always want them to inspect the skin around the cast daily, because remember, some casts are plaster, and many of us have seen casts. It's a coarse material, and so it can cause irritation if it comes into contact with the skin, and predispose that skin to break down and possibly infection. It says that we can place an adhesive tape over rough edges. Due to the increases in increases in technology, we have different type of casts that can be applied. And so it says here to avoid getting the cast wet. With the older type of cast, maybe the plaster cast, we had to be careful with getting the cast wet. With the there are casts out there available now that are okay to get wet. We want to avoid dropping articles into a cast. It's never okay for a person to stick a hanger into a cast to scratch the cast. To scratch the skin underneath. We want to call the primary physician if the cast cracks or if the cast breaks. If it breaks or if it cracks, then it's no longer doing its job. The purpose of a cast, if a patient has a break in the bone, is to maintain the stability of that bone. We're trying to keep that bone aligned so that the bone forms together, molds together again. That's the purpose of a cast. So if it breaks or if it cracks, it's no longer going to be able to maintain that alignment of the bone. When we have a patient that is in traction, traction is us maintaining again alignment of a bone. Traction we maintain is used with weights. Again, it talks about that in more detail in your book. When we have a patient that has weighted traction, we always want to make sure that the person has counter traction. And so with counter traction, we have a weight that's applied to an extremity, and that weight is going to be it's going to hang off of the bed, and the counter traction is the patient's body. Okay, so if we have a patient that's sliding to the edge of the bed and a weight that's resting on the floor, then that's not traction. We have to make sure that the patient is in the correct position in the bed. To avoid the patient sliding down to the edge of the bed, we may have to elevate the foot of the bed, but we also always want to make sure that we're maintaining the amount of traction that the doctor has ordered. We want to encourage a diet that's high in protein and vitamins because this is what promotes healing. The patient may need calcium, increased calcium, but again, protein and vitamins are going to promote healing. We want to encourage isometric exercise to promote muscle tone and strength. We have to teach appropriate crutch walking and technique as needed. Most of the time this is going to be performed by physical therapy, but what we want to be able to do is reinforce what we see physical therapy teaching the patient. So if the physical therapist has instructed the patient how to walk on crutches, but we see them doing it incorrectly, we have to be able to reinforce what we've heard the physical therapist teaching the patient. As far as pharmacology, we typically see opiates and non-steroidal anti-inflammatory agents being used for the patient that has sustained a fracture. The person may also be ordered antibiotics. This is for compound fractures and also for surgical reductions. Any type of surgical procedure, the patient may need antibiotics, prophylactic antibiotics, to decrease the risk for infection. Complications that we see associated with fractures. Non-union is a possible complication of a fracture. Even after the person has casting, after the person has traction, non-union can occur where the bones don't realign and adhere to one another. This may be the person that's in an immunocompromised state. Paresthesias can occur, and this is when the person has increased tingling in the area, maybe, and this could be due to nerve damage, because we learned in an earlier slide that a bone can affect all of the underlying structures. It can affect muscle, and it can also affect nerve endings. And so the person can have nerve damage as a result of fractures. Fat embolism. Fat embolism is a problem that we typically see when a person has a break in the long bones, such as the femur. It can also occur with the ribs, the tibia, and the pelvis. And so anytime we see embolism, that is not a good thing. But when we see fractures in the long bone, remember I said they're very vascular, and they also have fat in them. So the same way air embolus can hurt a patient, a fat embolism can hurt the patient as well. So emboli can travel to the lungs. Emboli can also travel to the brain. And so this is never a good thing when a person has an embolism. And so again, think of what we need to be assessing this patient for. We want to especially monitor this person in the first 12 to 72 hours after an injury. We want to make sure that we're assessing this, especially if they have a long bone fracture. A long bone fracture of the leg, we have to, in the first 12 to 72 hours, make sure that we're doing an adequate assessment of the patient's respiratory status. Any change in the respiratory status needs to be followed up. We're monitoring the person for any type of dyspnea, cyanosis, any type of tachycardia, any signs of poor gas exchange. This is a medical emergency. Again, I said it can travel to the lungs. It can also travel to the brain. So any change in nervous and in the person's sensorium, the person is more confused, the patient is more lethargic, maybe the patient is more restless. Also, we can see that the person has an elevated temperature. So we want to make sure that we're assessing for these things, and this is, again, a medical emergency. We're assessing the person for shock, and so early signs of shock may be a slight change in the patient's blood pressure. But we don't always see that because, again, remember, we have that heart, and so that heart is going to pump, 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 pump. So initially in shock, actually the person may have an elevated blood pressure, but then as shock continues to progress, then the patient blood pressure will drop. We're again going to assess for infection because of the break in the continuity of the bone, especially if it's an open fracture. With avascular necrosis, this is when the patient is not getting blood to that bone, and so that's not a good thing because here we know that we see necrosis, and so that's an area dying. And so if that bone dies, it's no longer able to do its job. It's no longer going to provide strength to that portion of the body. And so we have all of these are possible complications of a patient that develops a fracture. And so with a rib fracture, this is one of the most common blunt injuries that we see. And when we see blunt, this is something hitting. And we typically see this being sustained in patients that have been involved in motor vehicle accidents. So the signs and symptoms that we see being associated with a rib fracture, the person is going to have pain at the site, which worsens with inspiration, meaning when they breathe in. And so it kind of makes sense. If you think about the ribs are made out of bone. The ribs surround our lungs. So the lungs are housed inside of our ribs. So when the person breathes in, that broken bone is going to go in and it could possibly hit that lung. Or when we breathe in, or think about it the other way, when we breathe in, if you're practicing now, breathe in, our diaphragm comes up and the ribs come up. And so when that person breathes in, it depends now on the type of fracture the person have. That rib can go in or it can also go out, and so the person is going to have pain when they breathe in. The person is going to have shallow breathing. They're going to have shallow breathing that makes sense because it hurts this person when they breathe. And so all of you bright minds, I want you to think about what type of what type of acid-based problem is this person at risk for? Think about it. The person is going to have splinting of the area, which means that whenever they move or sneeze or cough, the person is protecting that area because it hurts, okay? The patient may have pain on palpation of that area, and they may also have crepitus at the site of palpation. Again, we're going to do a history and physical assessment on this patient. We want to know what happened. Was the patient involved in an accident? Was it a fall? Were they coughing and all of a sudden they had rib pain? That actually happens. When we have patients with metastatic bone diseases, this person can develop spontaneous breaks. So we need to do a history and physical on the patient. We can also do an X-ray. So our nursing management and education, this person that has a rib fracture should not have any strenuous activity for several days. They should try to, as much as possible, participate in deep breathing exercises every hour to prevent respiratory complications. Again, we said that this patient is at risk for an acid-based problem. They have shallow breathing. So again, you're thinking about what type of acid-based problem this patient is at risk for. We want to use analgesics as ordered. Again here, this is analgesics. Think about it. This person has a rib fracture. They already have shallow breathing. Why would we want to use narcotics very carefully with this patient? If we give this patient morphine that slows respirations, that wouldn't be smart in a patient that's already got shallow breathing. Not going to be a good thing. So we want to use analgesics as ordered. We want to call the primary care provider if this is not effective, because if it's not effective and it's not relieving their pain, this patient may need to be monitored. They may need stronger pain medications, but they may also need to be monitored in a critical care unit where they can receive assistance with their breathing, maybe ventilatory support. We want to assist the client in finding the most comfortable position. Generally, they will best be able to breathe in the Fowler's or the semi-Fowler's position. We want the patient to go to the ER promptly. Increased or sudden difficulties in breathing, this person should report to the ER. If they start spitting up or coughing up blood, if they have sudden, sharp, or increased chest pains. Sometimes when we have patients that have rib fractures, they may require chest tubes. If they develop blood in their lungs, they may have to have chest tube insertion. Again, with our pharmacology, we want to use analgesics with this patient, and so make sure that you're reading the different type of analgesics and the different type of medications that are used for these patients. Complications that we can see with a patient that has sustained a rib fracture, we see hemothorax, that's blood in the lung, a pneumothorax, that's air in the lung. They can develop a laceration of the liver, or they may also develop atelectasis, and that's poor lung expansion due to pain. I'm not going to go into a lot of detail with hemothorax and pneumothorax simply because we do discuss these in more detail in your 202 course. So we won't go into detail with these, just knowing that, again, a rib fracture is a fracture. With atelectasis, you've discussed this before in fundamentals, and you've probably gone over it this semester. And so with atelectasis, we know that this is a collapse in the lung tissue. And again, we see this when the person is not fully breathing in and out. So we don't have that full exchange of oxygen and carbon dioxide. And so that puts the patient at risk for atelectasis, and that's a collapse in the lung tissue. Age-related changes, the person can have increased resorption, increased bone formation, which lead to the development of osteoporosis. And we see an increased incidence of osteoporosis in the older population. And again, we're going to talk about that in more detail. We see progressive bone demineralization. That means that the bone is losing its minerals. This prolongs healing. There's a tendency toward joint stiffness. The joint spaces may become smaller as we become older, and so as a result of that, a decrease in the joint space and also decreased lubrication of the joint predisposes those joints to stiffness, and they don't move adequately, and this again puts the patient at risk for falls. We see a decrease in muscle mass and also in strength with age. Complications that we see, again, we can see the patient can develop deep vein thrombosis, also compartment syndrome. This is discussed on page 1650 in your book. And with the compartment syndrome, this is when a person has neuromuscular, neurovascular dysfunction. And this happens as a result, you have increased swelling in that area where the person has that fracture. And because of that swelling, then the person has more pressure on the vessels or the blood vessels. And so what we see is when a person has a fracture, again, we talked about increased bleeding, and so that person has increased edema, but as a result of that increased edema, it's obstructing the blood circulation in that area, and so the person has venous occlusion that develops. So make sure you read over that. Make sure you read over CAS syndrome. Talked about that earlier, when the person has on a body jacket and they develop nausea and vomiting as a result of that pressure on the duodenum. The person can also develop nerve damage. Again, with age-related changes, the bones can become more brittle. The patient may have mobility problems. Range of motion may also be decreased. We see falls being the most common cause of musculoskeletal injury and fractures in the older adult. Hip fractures are the leading cause of hospitalizations for injuries in the older adult population. And that is the end of our fracture lecture. So again, you all, that was a brief overview of musculoskeletal trauma. Again, you must read over the different types of surgeries that are associated with fractures. You need to go over the different types of fractures. You need to know the different type of injuries, the different type of cast are ordered for. You need to know how traction is used. You need to know the difference between skin traction, the difference between skin traction and skeletal traction. What's the difference between a closed reduction and an open reduction? I gave you, again, a brief overview of fractures, but again, you must know this information. Also, you must go over everything that is listed on that study guide. Chapter 63 talks about a number of things. You need to make sure that you go over sprains and strains. Also in this chapter, it goes over carpal tunnel. So make sure that you go over everything that you see listed on your study guide. And that ends our lecture on fractures.